Today we are going to talk about pediatric headache. Headache is the most common complaint in a pediatric emergency department or ambulatory clinic. Clinician's role is to determine primary from secondary causes. We will discuss about the approach, epidemiology, history taking, recognition of red flags, and appropriate diagnostic testing. Global 1 year prevalence for headache disorder is up to 85%, meaning most of the people in a given year get headache. The prevalence in children, 30 to 40%. In Austria and Norway, the number exceeds 75%. 1/3 of pediatric population experiences recurrent headache. Occurrence of headache among children increases with age. The most common headaches in children are migraine, tension type headache, medication overuse headache. Headaches are more common in girls than in boys. The postpubertal headaches are common in girls. In prepubertal age, migraine is predominant in boys. Even though CNS tumors are fearsome diseases that could cause headaches, the incidence is very low, 1.12 to 5 cases per 100,000 persons, or about 0.005%. Even though the incidence is low, as you all know, it has devastating consequences. Primary intracranial hypertension, the incidence is less than 1 per 100,000, even less than CNS tumors. The ICHD came up with the classification of headache. I colored in a way, the red tells you the primary headaches, the remaining are secondary headaches. Let's talk about primary headaches. So primary headaches means headaches with no underlying disease process that is causing headache. 1, migraine. 2nd, tension type headache. 3rd, trigeminal autonomic cephalalgia, like cluster headaches, primary hypertension, and SUNT. Other primary headaches like cough, exercise, sexual activity, stabbing headaches. So, history taking is the cornerstone in the diagnosis of pediatric headache. History is essential to distinguish between primary and secondary. Some children may be too young to answer the questions. There are 3 hypotheses for migraine. 1, vascular theory, meaning it causes vasodilation and vasoconstriction. The vasoconstriction episode causes aura in the migraine. And second part is cortical spreading of depression. I'm going to show you the slide in a minute. 2 to 3 millimeter, the cortical spreading moves 2 to 3 millimeter per minute. Third, trigeminal system release vasoactive neuropeptides, substance P and CGRP. CGRP is a calcitonin gene-related peptide. The cortical spreading of depression occurs similar like this. It starts in occipital lobe and spread in the front. So aura usually have symptoms arising from occipital lobe most commonly, and it depends upon how far it has spread. You can have sensory, phonetic, and sometimes hemiplegic, especially when the cortical spread go past the central sulcus involving the motor area. The core point of migraine center around dorsal raphe nucleus and locus coeruleus. It receives a nociceptive stimuli and modulates it, and it sends a signal through these nerves, through the pterygopalatine ganglion and trigeminal ganglion, and releases Now we know it is CGRP that causes vasoconstriction and vasodilation. So how often and when did your headache start? Number one, establish headache temporal pattern. The Rothners came up with 5 temporal patterns in the headache. 1, acute; 2nd, acute recurrent; 3rd, chronic progressive; and 4th, chronic non-progressive; and finally mixed. Acute headaches, this is a single episode or new onset of headache, typically associated with systemic or neurologic symptoms. Viral illness is a frequent cause of an acute headache. It accounts for about 60% of headache in children. The worst headache following Valsalva maneuver or thunderclap headache raises concern for aneurysmal subarachnoid hemorrhage. The second temporal pattern is acute recurrent headache. The periods of complete freedom from symptoms between the headache attacks. The pattern seen in migraine and tension type headaches. It is also seen in TACs and cranial neuralgias. If this pattern has been ongoing for at least 6 months, a neurologic examination is normal, further workup is not indicated. Third pattern, chronic progressive headache. In this type, the pattern that gradually increases in frequency and severity over several months. It may indicate the likelihood of increased intracranial pressure. Other neurologic symptoms and abnormal neurologic examination usually accompany this pattern. So when you have a chronic progressive headache, one should investigate to look for ICP and other causes. Chronic non-progressive headache. It's a pattern of frequent, intermittent, or daily constant headache with normal neurologic examination. Headache more than 15 days per month for more than 3 months, with each headache lasting more than 4 hours. Psychosocial stressors are commonly present in chronic non-progressive headache. The final temporal pattern is mixed headache. The long-standing headaches such as chronic migraine with a superimposed acute and or acute recurrent headache. The superimposed headache can be another primary headache or a secondary headache. So what are the causes of these 5 temporal patterns? Acute headache, as we said, most commonly infection. The infection could be paranasal infection, URI fever, sinusitis, otitis, pharyngitis, meningitis. Subarachnoid and intracranial hemorrhage, stroke, hypertension, metabolic causes such as hypoglycemia, hypercapnia, and hypoxia, post-seizure, substance abuse, intoxication, and trauma. Acute recurrent headache, migraine, tension type headache, cluster headache, paroxysmal hemicrania, exercise headache, cranial neuralgias. Chronic progressive headache, CNS neoplasm, brain abscess, subdural hematoma, hydrocephalus, chronic meningitis, and primary idiopathic hypertension. Chronic non-progressive headache, chronic migraine, chronic tension type headache, post-concussion, medication overuse headache, depression. Mixed headache, primary headache disorder like chronic migraine, chronic tension type headache with superimposed secondary or another primary. Where is the location of your headache? A brief side-locked headache is a characteristic for TAC. Occipital headache, specifically when it's associated with abnormal neurologic examination, is an ominous sign for posterior fossa tumors or lesion in the cranial cervical junction. Occipital headache with the normal neural examination, there is no increased risk of intracranial pathology if the examination is completely normal. Localized pain can be seen in patients with otitis media, temporomandibular joint dysfunction, optic neuritis, or maxillary sinusitis. Next question is, what does your headache feel like? Migraine is typically described as throbbing or pounding. Pressure or dull are descriptors used for tension type headache. Sharp, stabbing, jabbing are words used to describe primary stabbing headaches or TACs. Shooting or shock like pain is common in trigeminal neuralgia. So the type of the headache you can identify by the pain patterns. How long does your headache last? There's another crucial question during history. Distinguishing headache duration between long lasting headaches from short lasting headaches, seconds to minutes. It can distinguish migraine from TACs and cranial neuralgias. Migraine in younger children can be as short as 2 hours. Other symptoms accompany your headache. Fever with behavioral changes indicate infectious process, most likely meningitis or encephalitis. Early morning or nocturnal vomiting progressively worsening may indicate intracranial mass. Pulsatile tinnitus in an obese child can be from primary idiopathic hypertension. Numbness and or paresthesia, dysarthria, vertigo, and motor weakness can be an oral symptoms of migraine. Vascular or demyelinating processes must be excluded. Autonomic symptoms such as lacrimation, facial flushing, and or sweating, nasal congestion, and ptosis are associated with symptoms of TACs. This can be present in pediatric migraine. What triggers your headache and what makes it better or worse? This is another important question to distinguish from primary to secondary. Any headache provoked by straining, cough, exercise, physical exertion, or Valsalva requires exclusion of secondary cause. Postural aggravation on upright position, especially following spinal tap, indicates intracranial hypotension. Worsening of headache on supine position indicates intracranial hypertension. So, elucidating what triggers and what makes it better is very important in making most of the time rule out secondary causes. Do you take headache medication or other medication for other medical conditions? Headache with visual obscuration in a patient taking minocycline or growth hormone may indicate secondary intracranial hypertension. Teenager with headache and seizure on contraceptives can have cerebral venous sinus thrombosis. The frequent use of analgesics or triptans may lead to medication overuse headache. Adolescents should be screened for substance use such as THC. It can cause reversible cerebral vasoconstriction syndrome. Do you have other medical conditions? New onset headache in a patient with a known malignancy can indicate metastatic disease. Opportunistic infections can occur in an immunocompromised patient presenting with headache and fever. Connective tissue disorders such as Ehlers-Danlos may have cervical arterial dissection presenting as a thunderclap headache. It can be spontaneous. Anxiety and depression can contribute to perpetuation or worsening of headaches. Is there a family history of headache or neurologic disorder? Migraine is an inherited disorder, and the absence of family history of migraine has been regarded as a predictor for SOL, space-occupying lesion, and the need for neuroimaging. So in the absence of family history, one should rule out space-occupying lesions. Not all parents know their family history. There is another issue with the family history. Vascular malformations are heritable as well as genetic conditions with the predisposition to tumors such as neurofibromatosis and tuberous sclerosis. Detailed history and examination uncovers headache red flags. So simplified approach introduced by Dodick in 2003, Snoop to identify red flags. Then Kibushi and Cleves came up with Snoopy to identify red flags, especially in pediatric patients with headache. So what are the history and physical examinations one should focus? One, look at the vital signs: blood pressure, heart rate, temperature, and BMI. Hypertension may be the cause of headache or a sign of increased ICP. Fever suggests an infectious process. Elevated BMI raises suspicion for PAH. In children, head circumference is very important to measure in all patients with headache. Macrocephaly may indicate an elevated ICP that is slowly progressing. Head and neck examinations, very important. Pericranial tenderness may suggest migraine and tension type headache. Tenderness on the back of the head may indicate occipital neuralgia. Paranasal sinus tenderness may indicate sinusitis. Nuchal rigidity in the proper setting can signify meningitis. Cranial, orbital, and cervical bruit may indicate vascular malformation. Fundal examination needs to be done in all patients with headache in children. I'm sure the same thing is true in adults too. Look for papilledema, absent venous pulsation. Hemorrhage may indicate increased ICP. Mental state changes. Fluctuating mental states may indicate elevated ICP, intracranial hemorrhage, or encephalitis. Dysarthric speech may indicate stroke or vascular event. In neuroexaminations, look for pupillary reaction, ocular mobility, visual fields, asymmetric facial movements, motor and sensory deficit, abnormal deep tendon reflexes. Cerebellar signs may indicate intracranial pathology. Another important is skin. Look for neurocutaneous stigmata like neurofibromatosis, tuberous sclerosis, can be highly associated with intracranial tumors and vasculopathy. Presence of rash may suggest autoimmune and infectious processes. Presence of bruises may indicate trauma or bleeding disorder. In adolescents and also in young adults, always ask or look for substance use. This is a Snoopy mnemonic for the evaluation of pediatric headache and need for investigation, otherwise red flags in patients with pediatric headache. The S stands for systemic symptoms or illness: fever, altered level of consciousness, anticoagulation therapy, pregnancy, cancer, HIV infection. N stands for neurologic symptoms and signs: papilledema, asymmetric cranial nerve function, asymmetric motor function, abnormal cerebellar function, new seizures, and focal findings at examination. O stands for onset recently or suddenly, like thunderclap headache, suggestive of subarachnoid hemorrhage. O, occipital localization of pain. There are 4 P's involved: precipitated by Valsalva maneuver, positional, progressive, and lack of family history. The Y, years less than 6 years. So these are all the red flags in pediatric headache. The most common primary headache is migraine. Without aura, called common migraine; with aura, classical migraine. Typical aura, it can be familial hemiplegic migraine, sporadic hemiplegic migraine, basilar type of migraine. Sometimes episodic syndromes associated with migraine, such as cyclical vomiting, abdominal migraine, and benign paroxysmal vertigo. Retinal migraine, and the complications of migraines are status migrainous and migrainous infarction. What is migraine without aura? More than 5 attacks. Each attack lasts for 4 to 72 hours. It is often unilateral, pulsating. The pain category is more than moderate, aggravated by physical activity. It's often associated with nausea, vomiting, photophobia, and phonophobia. Migraine with aura. What is aura? Reversible focal neurologic symptom that develop gradually over 5 to 20 minutes and last less than 60 minutes. This is because of decreased regional blood flow. As I have mentioned before, it starts from occipital lobe all the way it can go up to motor area. Based on the transmission happened, how long it you will have a different kinds of symptoms. The typical aura has visual, sensory, and speech. Sometimes in patient with familial and sporadic hemiplegic migraine, you will have weakness. In basilar type, you will have brainstem and both cerebral hemisphere signs and symptoms like dysarthria and all those stuff. Hemiplegic migraine. The familial migraine, wherein one you will have a family history of first or second degree relatives. Aura symptom lasts more than 5 minutes and less than 24 hours. It is associated with genetic abnormalities like calcium channel abnormality, ATP abnormality, and sodium channel abnormalities. The calcium channel abnormality is specifically associated with ataxia, coma, and CSF pleocytosis. Another type of hemiplegic migraine is sporadic hemiplegic migraine. Basilar type of migraine affects 3 to 19% of children with migraine. Within the migraine subgroup, there is almost like 1/5, less than 1/5, can have basilar type of migraine. Usually it affects adolescents. Start with occipital headache, have dysarthria, vertigo, tinnitus, diplopia, ataxia, decreased level of consciousness, bilateral numbness, and no weakness. Then another group, confusional migraine, confusion state superficially resembling psychotic reaction, mostly adolescents. Cyclical vomiting. It is episodic, stereotypical attacks of intense nausea and vomiting lasting 1 to 10 days. Vomiting occurs at least 5 times per hour for at least 1 hour. Symptom free between the attacks. It is not attributable to any other cause. Very important thing, you need to make sure there is no other cause for the vomiting. So how do you treat cyclical vomiting? Hydration and correction of electrolyte imbalance. Treat with benzos and diphenhydramine. Antiemetics such as ondansetron, promethazine, metoclopramide, prochlorperazine may be indicated to decrease the vomiting in these patients. So how do you treat this one? Most of the time, if it becomes really problematic, prophylaxis needed. Often you treat with cyproheptadine, amitriptyline, valproate, topiramate, propranolol, and verapamil. Most of the time, they end up receiving cyproheptadine and amitriptyline or Topamax too. Topamax is being widely used right now. In abdominal migraine, you will have more than 5 attacks. Each attack lasts for 1 to 72 hours. The pain is midline, periumbilical, moderate to severe. They often have anorexia, nausea, vomiting, and pallor. I want to emphasize when you have anorexia with abdominal pain, just make sure the patient does not have other underlying diseases like inflammatory bowel disease. Return to normal between episodes and rule out other causes. Very important. Especially when you're dealing with abdominal pain, make sure we are not missing any other cause for the abdominal pain. Next one is benign paroxysmal vertigo. More than 5 attacks, severe vertigo for minutes to hours. These patients will have normal neurologic exam, audiometric and vestibular functions between the attacks are normal. Another category is benign paroxysmal torticollis, usually seen in infancy, lasting hours to few days, at a frequency of every weeks or months. Apparently, benign paroxysmal vertigo, benign paroxysmal torticollis, even infantile colic, everything comes under the migraine category. Next, tension type headache. It is episodic or chronic, lasting 30 minutes to many days. It is often bilateral when compared to migraine. Migraine usually unilateral. Pressing and tightening. There it is throbbing. Mild to moderate, not aggravated by routine activity. There is no nausea or vomiting associated with tension type headache. These are a contrast between migraine and tension type headache. No more than one of photophobia or phonophobia. So when you have a typical aura, unilateral, typical, the pain that distinguishes tension type from migraine. So in the examination, you should thoroughly examine the skin for neurocutaneous manifestations like KPLI spot in neurofibromatosis, Ashleigh macules, as you see in tuberous sclerosis. All patients with the headache needs to have their retina examined for papilledema and other reasons for headache. The high pressure will be seen in idiopathic intracranial hypertension or pseudotumor cerebri or sinus venous thrombosis. The low pressure headache you see in lumbar puncture, spontaneous CSF leak in patients with Ehlers-Danlos syndrome or other connective tissue disorders that could cause spontaneous rupture. Obtaining a neuroimaging study on a routine basis is not indicated in children with recurrent headache and normal neurologic exam. So only when the patient fits in Snoopy criteria, then you need to investigate further. Otherwise, routine imaging studies is not indicated. The studies often we do are CT, MRI, and MRV. Most commonly, MRI is the best tool to do it. And of course, based on what we are looking for, one need to choose which one is better in that particular patient. When you suspect infection, one need to do a spinal tap. Now, how are you going to treat? First, non-pharmacologic treatment. There is a smart recommendation for lifestyle targeted treatment regulation for migraine. The SMART comes from sleep, meals, activity, relaxation, and avoiding triggers. Work to achieve adequate sleep for age. Encourage regular sleep schedule. Optimize overall sleep quality. The duration is important and the quality is important. Meals. Obesity linked to the increased migraine frequency. Maintain a consistent meal schedule and avoid meal skipping. Eat a healthy, balanced diet. Aim to drink half of your body weight in pounds in ounces of water. For example, 120 pounds means 60 ounces of water. Inactivity is linked to obesity. Aim for 30 minutes of physical activity 5 days a week. Limit screen time to 2 hours per day. Relaxation. Relaxation training such as mindfulness, deep breathing, and biofeedback may be helpful in reducing stress and anxiety. Triggers. Keep a headache log to identify potential triggers, but remember, triggers are often cumulative. Reduce exposure to consistent migraine triggers. So each and every individual can have different triggers. So having a headache log will help you to identify what causes headache and what causes headache intensity to be higher or what relieves. The most commonly used medications are analgesics like ibuprofen, acetaminophen, naproxen, salicylic acid, opioids, butalbital, caffeine, and ketorolac. Triptans are often used in fact, more widely right now, sumatriptan, risatriptan, solmitriptan, olmotriptan, elatriptan, and two more. In severe patients, we use ergot alkaloids, especially DHE, dihydroergotamine. The dose is 6 to 9 years, 0.1 per kilo, 0.1 per dose. 9 to 12 years, 0.2 milligram per dose. 12 to 16 years, 0.25 milligram per dose, and increase after the first dose. If the patient has associated MSs, one should use Phenergan, Compazine, Reglan, and Sofran. Some patient may need IV MAG and IV valproic acid. The triptan medications approved in pediatric population are as follows. Risatriptan, 5 milligram, 10 milligram, it's available in tablet and dissolved in tablets. It's approved for 6 years and up. Sumatriptan and naproxen is combination medication available in tablet, again approved for 12 years and up. Somitriptan, 2.5 and 5 milligram, it's available in tablet and nasal spray, approved for 12 years and up. Olmotriptan, 6.25, 12.5 tablet, approved 12 years and up. Even though it is not recommended less than 12 years, off-label use you can see, especially in patients who are not responding to lifestyle modifications and regular analgesics. The most important is a chronic debilitating disorder. So prevention is the most important part of treatment. Prevention is necessary, especially it disables them from going to or school or doing stuff at the school in a productive way or working. If it is more than 2 times per week, or when there was a medication overuse because of constant headache, when there was no response, adverse reaction, or contraindication to acute treatment. In hemiplegic migraine and basilar migraine, in these patients, prevention is very important. The first preventive measures from nutraceuticals, like giving MAG, magnesium, 9 milligram per kilogram per day, nightly elemental magnesium. Typical dose is 400 milligram if for patients more than 40 kilos. Riboflavin, 100 to 200 twice a day. Coenzyme Q10, 100 milligram to 300 milligram daily. Melatonin, 3 milligram to 6 milligram nightly. So whenever you take the medicines, make sure you look for side effects in case if you have side effects, and of course you need to reduce or modify the dose. Second, prescription medications. 1, amitriptyline. It is a tricyclic antidepressant, 1 milligram per kg per day nightly. But one has to remember the side effects, especially QT prolongation, because it is a TCA. Nortriptyline, 10 milligram to 75 milligram nightly, max 150 milligram, similar to amitriptyline because it is a TCA. Venlafaxine, 37.5 to 150 milligram daily. It can cause hypertension, tachycardia, insomnia. This is the SSRI inhibitor. Topramat, very often used, 2 to 3 milligram per kg per day, divided twice daily, max 200 milligram daily. It's an anti-epileptic. It can cause cognitive slowing, word finding difficulties, weight loss, paresthesia, kidney stones, glaucoma, and decreased sweating. Propranolol, 1 to 2 milligram per kg per day, divided twice or 3 times daily. Hypertension, bradycardia. Use cause in patients with especially asthma and diabetes. Canton-Sartan, 4 milligram to 16 milligram daily. ARB inhibitor. Verapamil extended, 4 milligram per kg per day. It can cause hypertension, dizziness, and constipation. Memantine and cyproheptadine. I want to mention this, 1.25 milligram per kg per day to 0.5 milligram per kg per day, max 16 milligram. It can cause sedation, weight gain, sun sensitivity. It is an antihistaminic. It improves the appetite, thus weight gain. So pharmacologic treatment is anticonvulsants, antidepressants, antihistamines, beta blockers, calcium channel blockers, and botulinum toxin A. Few centers use botulinum toxin A because it prevents the release of CGRP. So when you have associated hypertension, so you choose the medication based on associated comorbidities. For example, the patient has hypertension, choose beta blockers, calcium channel blockers, and ACE inhibitor. Anxiety, beta blocker. Depression, TCA. Sleep, TCA and cyproheptadine. Having pain elsewhere, use gabapentin. Obese, Topamax, and zonisamide. Liver disease, levetiracetam, gabapentin, and Botox A. So you choose the medication based on the underlying comorbidities with headache. Important caution. Avoid beta blockers, triptans, and ergotamine in basilar, hemiplegic, and migraine with prolonged. In those patients, consider verapamil. Finally, CGRP. What is CGRP? It's calcitonin gene-related peptide antagonist. What they found was in all patients with migraine, the CGRP, the calcitonin gene-related peptide, is elevated. Then this devised medications to stop or the calcitonin gene-related peptide. This is a mainstay of therapy in adults at this point. We have only one medication approved in pediatrics, 6 years and up. Nevertheless, I need to touch upon it because this is going to be the mainstay of therapy from triptans to CGRP antagonists. There are 4 ways it can be stopped. 1, regular CGRP receptor activation. 2A, monoclonal CGRP receptor antibody like erinimab. Monoclonal CGRP ligand antibody. 3rd, small molecule targeting CGRP receptor. So in 4 different ways it can be blocked. The CGRP monoclonal antibodies are as follows. Now it is approved, the erinimab, Fremanezumab, and these are all approved for prevention in episodic migraine and chronic migraine. These first 3 are available only in subcutaneous injection. So only this Fremanezumab, it is available as a Jovi. It is available, it is approved for children 6 months and above, 6 years and above. The dose is for erinimab, 70 milligram or 140 milligram monthly. For Fremanezumab, 225 milligram monthly or 675 milligram every 3 months. Subcutaneous injection, it is approved in children aging 6 years and up. It was approved August 2025, just a few months ago. If you use galcanezumab, it's adults. And 240 milligram loading dose, then 120 milligram monthly. Eptinezumab, IV infusion, 100 milligram or 300 milligram every 3 months. And other medications available by mouth. 1, the oral disintegrating tablets for prevention of episodic and chronic migraine. Dimegepant, 75 milligram every other day for prevention. Atogepant, prevention of episodic and chronic migraine daily. Ubrogepant, acute use in emergency medicine, episodic migraine, 50 milligram, 100 milligram daily. So this is a significant change in the headache management, migraine management from triptans to CGRP monoclonal antibodies. In summary, start with education and lifestyle change. Treat headache and comorbid condition. Start low dose and build up slowly. Discuss realistic expectation, adequate trial for at least 2 to 3 months of optimal dose before you call it this medication is not working. Alternative medications, nutraceuticals, we already talked about magnesium, riboflavin, coenzyme Q, melatonin. Some people resort to acupuncture, chiropractic. The botulinum toxin A has been used in centers because it also blocks CGRP release. Relaxation therapy, biofeedback, and cognitive behavioral therapy sometimes helps if nutraceuticals and other medications did not help. The other modality is stimulators. The stimulators are available and done by multiple companies. What do? They do not alleviate the pain, but they modulate the pain, especially after we failing lifestyle modification, analgesics, triptans, and now CGRP. We do not know a whole lot about CGRP, how effective, and currently, if they fail at the triptans, they go to stimulators. Finally, post-traumatic headache. It happens within 24 hours to weeks. It clears within 2 to 3 months. It is associated with vertigo, dizziness, difficulty concentrating, memory disorders, depression, altered school performance, behavior disorder, sleep alteration. The severity of symptoms does not depend on severity of head injury. It can be a second impact syndrome, meaning cerebral edema or afraid of death. Return to play after discussion you need to do, and CT MRI most of the time it's done in the emergency department. Neuropsychological testing if there is no improvement or evidence of school failure. Symptomatic treatment, educate the patients, non-steroidal anti-inflammatory drug, physiotherapy, amitriptyline, topiramate, and cyproheptadine can be used in post-traumatic headaches. These are the practice guidelines by American Academy of Neurology for concussion management. In grade 1, meaning there is a chance in confusion, the concussion symptoms less than 15 minutes, and return to play if there is no symptoms for 15 minutes. The grade 2 is a chance in confusion, concussion symptoms more than 15 minutes, return to play after a week. Grade 3, loss of consciousness, had a chance, loss of consciousness, transport to the hospital, return to play after 2 weeks. These are all the guidelines you should give it to the parents or the patient. This concludes the talk on pediatric headache.